Hello and welcome everyone to our webinar Wednesday for Breast Cancer Awareness Month. I don't know if you can see this on my screen, but I'm getting an error when I try to advance the slide. I'm getting a beach ball, so I'm going to stop sharing my screen.
We can see it.
Oh, okay. Well, I couldn't advance the slide for some reason. I'm having a lot of technical issues right now, and I'm not quite sure why. But in the interest of time, I'd like to just get started with our webinar and our speaker today, who has to jump off a little early to get to a procedure. So our speaker today is Dr. Kirti Kulkarni, and she is joining us as a radiologist from the University of Chicago. And she'll be speaking to us today about breast screening and breast cancer. And Dr. Kulkarni, I'm just going to have you go ahead and share your screen so we can go ahead and get started.
Thank you, Alia, for the introduction. Can you guys, so do I have to, again, share my screen? Okay. Can people see my screen?
Yep, looks good.
Okay, I'm going to move this on the side. So thank you once again, Alia, and everyone from the Comprehensive Cancer Center for inviting me, especially given that it's Breast Cancer Awareness Month. What better topic than to talk about breast health, and specifically talking about how breast health could be a priority for all of us. I've been at the university now for the last 10 years. I did my fellowship in breast imaging also at the university. And I've seen every year in the month of October, when it's Breast Cancer Awareness Month, there are tons of activities that happen. And I'm just impressed with the marketing team and the radiology team, for putting up all of these events this month. I personally think that these conversations and these ideas should be part of our discussions, not just in the month of October, but throughout the year, because we see these patients on a daily basis. Breast cancer, everyone knows the statistics, it is harsh. Every 1 in 8 women will be diagnosed with invasive breast cancer sometime during their lifetime. In 2021, approximately 280,000 women is estimated to be the burden of new cancer diagnosis of invasive cancer only, and DCIS is approximately 50,000. So it is not something that we don't know about, but it's nice to have these conversations, make awareness, make people aware of their options. And I think breast imaging or breast cancer treatment, screening, prevention, all of these have changed and evolved in the last, I would say, a decade. It's become modernized. Even our technology has modernized. We have newer equipment and newer tools to offer you as well. So I'm going to talk briefly about these things today. So, whenever we think of breast health or breast cancer, breast-related things, what comes to people's mind? I'm going to just play a little word jargon here, but most of the times people think of age, genetics, mostly females, but males too do develop breast cancer. People think of spread and metastases. Often when, if you talk to a breast cancer newly diagnosed patient, they're talking about their family members and kids. And then we talk to survivors and the effort and the resilience that they need to have for the survivorship. Financial toxicity is big. And when it comes to mammograms, breast compression, pain, all of those are the negative words that come to people's mind. But this is what I want people to think of, what we offer at University of Chicago. We definitely have compassion and empathy, and it's a very team-based approach. We have a great team of surgeons, oncologists, radiation oncologists, medical oncologists, plastic reconstructive surgeons, pathologists, and radiologists who make up this team. And I cannot emphasize how much we rely on that team approach. We focus on life beyond cancer. We focus on giving them empathy and compassion. We want to tell patients that you're not alone in this. And we take care of the psychosocial aspect of breast cancer. And there are also nurse navigators as part of our team. So definitely wanted people to think about that other spin as well. So there are NCCN guidelines for breast cancer screening. This is a typical conversation between a doctor and a patient. What is the doctor trying to, or I would rather want the providers to have this conversation early on. And most of the guidelines now recommend starting by the age of 30 to have this conversation with the patient. Let us talk about your breast cancer risk assessment, Mrs. Smith, and then what would be a typical response? That would be great. What is risk assessment? How do we do it? So I think these are very important questions, and this is the beginning of that discussion. So even before the patient reaches the mammography suite or reaches the radiologist, as you know, we work a lot behind the scenes. Most of the work is done by the doctors that are on the forefront, the primary care physicians, the OBGYNs. These patients rely a lot on, because they have a better rapport with those doctors. So they rely a lot on the information that is passed down from them. So I feel these conversations are sort of a segue into what recommendations and what the guidelines are for breast cancer. So who is at risk? The first question when anyone asks me about breast cancer screening is, are you average risk or high risk? And how can one find out? People always think, I didn't have any family history of breast cancer, so I am not at risk. But I don't think so. The answer is that simple. Almost 80 to 85% of breast cancers occur in patients who do not have family history of breast cancer. That means they don't have so it's not the inherited genetic makeup. It's because of some sort of a genetic mutation, which is not related to their mom or dad. All cancers have some genetic predisposition or genetic. The reason behind this is genetics, but there are a lot of other risk factors and other reasons that I will touch upon as well. So lifetime risk of more than 20%, as defined by, there are multiple models out there like Tara-Cusick model, Gale model, that depend a lot on multiple factors. Some of them are family history, and other factors like, do you have dense breast? Have you had multiple breast biopsies, so on and so forth. But there are other patients also that are considered a risk. Did you get chest radiation at between the age of 10 and 13? Then you definitely need to be in a higher risk, and there should be a different test that needs to be offered to you. 5-year risk of invasive breast cancer is more than 1.7% in individuals more than 30. So personal history of breast cancer is a big one. So if you have already had that history of breast cancer, then definitely we want to, especially at a younger age, we want to screen you more with a different tool, not just X-ray. Mammography is an X-ray of the breast. If you've had multiple breast biopsies, especially with pathology showing ADH, atypical ductal hyperplasia, or ALH, LCIS. Then dense breast, patients with Ashkenazi Jewish descent, Black women. So I personally think no one test can fit all. I know the current recommendations is annual screening mammogram starting at the age of 40 for an average risk woman, and that is a huge benefit of doing that test. But once you're in the high risk category, I think we have other tools that we can offer you. Our big one is, which is like the Tesla of the cars, I would think, is the MRI, the magnetic resonance imaging. It's not the CT scan. Does not include radiation. It's magnetic resonance imaging. Before we jump to what tools to use, I think it's very important that these high-risk women get a clinical encounter, they meet with a genetic specialist, have detailed discussion, understand what their genetic makeup is, make sure they're aware of their options, and then also work on some risk reduction strategies. So I'm going to talk a little bit about each. So the screening tools that we, the radiologists, offer are typically mammograms in average risk women starting at the age of 40. But once you're high risk, we begin screening 10 years prior to when the youngest family member was diagnosed with breast cancer. not prior to age 30 or age 40, whichever came first. What it means is if your mother was diagnosed at the age of 45, then it's -10. So you would start screening at the age of 35. With MRI, because mammogram might not be enough, so we want to add MRI to this pool of patients. We begin screening with annual MRI 10 years prior to when the youngest family member was diagnosed with breast cancer, not prior to age 25 or age 40, whatever comes first. There are other tools available like automated whole breast ultrasound, or contrast enhanced mammography. We do not have contrast enhanced mammography at our institution, but we do have mammogram, MRI, and whole breast ultrasound test. A little bit about each test. A mammogram is obtained. It's an X-ray. So essentially, it tells you what the breast is comprised of. And breast is comprised of glandular tissue, which is white, and it is made up of fat, which is black. It also has the ductal system, which are the ducts, and then it has the fibrous component, which holds the breast together. There are 4 categories of breast density, which can be diagnosed on a mammogram. I don't think so one can feel the breast, do examination of the breast and say that I have category A or B or C or D breast density. Also, I want to say that the breast bra cup is not the same as the breast density. So also the firmness of the breast is not related to the breast density. Breast density is something that we see on a mammogram, which is an X-ray of the breast. And if you are in category C or D breast density, which means it has more glandular tissue than fat, more than 50% in category C and more than 75% in category D, those patients are called patients who have dense breast. And almost 40% of patients have dense breast, which is category C or D. It is harder for the radiologist to spot the cancer if you have category C or D breast density. And I think it might potentially mask a small cancer. That's why getting that adjunct screening in form of a whole breast ultrasound or an MRI is very, very important. And the breast density law was passed in 2019, and since then the insurance companies allow these tests to be complementary tests along with a mammogram. No test will replace the other test. I know I'm talking about multiple tests here, but no test replaces the other test, because we radiologists are looking for 2 things on a mammogram. One is a mass or distortion, which is white, and the other is white dots of calcium, which are sort of dead cells that are growing within a ductal system. And these are seen, the calcium dots are seen on the mammogram the best. So some of the risk reduction strategies are, again, I'm not the specialist for it. A genetic specialist or genetic counseling will definitely help you. In our clinic, when we come across a patient with a strong family history of breast cancer, or someone with a young diagnosis of breast cancer, or if any of those risk factors that I mentioned earlier, we give them a flyer that talks about the high-risk clinic, and we tell them to get an appointment with one of the individuals from the high-risk clinic. And I think it's a very important understanding of what research opportunities these patients can have. They could also get their genetic makeup by just a basic blood test or saliva test. And I think these are very important tools of understanding what your body is made up of. You can always do some of the risk reduction strategies, like work on a healthy lifestyle, eat more fruits and vegetables, less processed food, less sugar or no sugar for that matter, and do moderate exercise every day for 30 minutes, minimize the amount of alcohol, not more than 5 drinks a week, no smoking, no tobacco. Those are generally good, healthy lifestyles for anything in your body, because whenever there is any sort of a DNA mishap or misprogramming, as I think of it, your cells can actually repair or attempt to repair those and prevent your body from going through any sort of mutation to a large extent if you have healthy choices and risk reduction options. So what are these elements of risk? I know there are some that are in our control, but some that are not, right? Like family history, not in our control, but at least it's in our control to find out about the family history. It's important to find out, especially people who are adopted or people who've lost their family members early on in their lives. I think it's nice to at least get some information about what is that, or at least you could do the genetic test. Increased age, ethnicity, race. I talked about African American Black women have a higher risk breast cancer, dense breast tissue, just because of the sheer amount of breast tissue is more, also have increased risk of breast cancer. I think there are multiple features that have been studied to understand, although the incidence of breast cancer amongst the Caucasian and the Black women is the same. Why is it that Black women have higher mortality rate? And some of the things that people have thought about is it the genetics behind it? Is it the biology of the cancer that dictates how it would present it for them? Or is it some other factors like disparity in healthcare accessibility between those populations? But these are very important questions, and we're even, especially at University of Chicago, spearheaded by Dr. Olapati, these have been some of the disparity-related research that have been going on. I briefly talked about lifestyle factors, but also reproductive age group. Did you have kids later in your age? Did you not have kids? Have you had multiple breast biopsies? Those are certain elements of risk. The Breast Cancer Awareness Month was really well celebrated. I thought there were a ton of material out there for patients. There were postcards mailed to them. There was things that were on Facebook Live. There was also a radio show that happened. There were multiple survivors that were interviewed, and they were like inspiring stories for other breast cancer patients and women to just feel empowered about their breast health and feel that there is life beyond cancer. So these are some of the kind of snippets that I thought I should show you guys. This was one specifically that talked about what to do at each decade. I thought that was really nice how you start with self-exams, because you know your breast health or your breast composition the best. And then at 30, you start talking about your risk factors. At 40, you get your mammogram. And, with menopause, things can change in your breast, but be aware of what's happening and be aware of the tools that you have besides breast, besides mammogram. And in your 50s, in your 50s, and then in your 60s and 70s, don't break the habit. Certain red flags, red alerts. If you feel lumps in your breast when you're doing self-exam, if dimpling of the skin, any skin changes, nipple discharge, any new focal breast pain, definitely contact your primary care physician or OB. Get an appointment with the breast radiologist. What we typically do is start with a mammogram and do a targeted ultrasound to find if we find anything suspicious. And if we do find anything suspicious, we go ahead and do a needle biopsy in that case. Here are some of the other events. This was a really nice radio event that I was a part of with Fayan Hathaway, and she's a certified genetic specialist, as she calls it. And it was and Kalia Copper was also there. And congratulations to the Chicago Sky team for winning the championship. And this, I think, was the day before they won the championship, was this radio show. It was wonderful. I think it was people got connected to the story because Kalia herself has a family history of breast cancer in her mother and grandmother, and we talked to her about what are her next steps and what should her mother be doing and her siblings should be doing. So definitely it was an eye-opening conversation. This was another Facebook Live event that was with, again, with Fayan, discussing about the importance of early screening, breast cancer screening, the tools that are available, and the genetic counseling. That is very important. Once the patient has symptoms, then it's not screening anymore, it's a diagnostic workup. And I think I already mentioned these patients definitely should come to us and we will do the necessary test for them. If it's less than 30, we start with a mammogram. More than 30, we start with, less than 30, we start with an ultrasound. More than 30 years of age, we start with a mammogram first and then do an ultrasound and then figure out if things need biopsy or not. There are tons of research studies that are going on at the University of Chicago. Specifically wanted to talk about a few. If patients have dense breasts, then we do offer specifically alternate screening tools. We have a whole breast ultrasound examination option, but we also have abbreviated MRI or a short interval MRI, which is a safe test. And it is a test that I feel is going to be probably the test for patients who have higher risk of breast cancer. It is getting more safer and safer. There are better MRI contrast agents that have been FDA approved, which don't linger or deposit in your body, but get washed out easily through your renal system, through your kidneys, and are more safer. We are trying to work on how we could do this test with minimal amount of that contrast agent injected. And also at some point, we probably will come up with a technology where we don't need any contrast injection, but it is capable of finding small cancers that are less than 5 millimeters, cancers that really matter, cancers that can be aggressive. Also, we have the CAP study, which is the Chicago Alternate Prevention Study. This is a wonderful study for patients who have a strong family history of breast cancer or have a genetic mutation that has been diagnosed, or patients who have dense breasts. And there are 2 screening scans per year that are offered. And we have a newer technique in breast MRI called the ultrafast, or a really fast technique of breast MRI, which is used in this particular research study paired with the abbreviated or the shorter version of MRI. So the study, the goal is to see if with that short time interval MRI, could there be a safer screening alternative than for patients to get a prophylactic mastectomy or get a more aggressive surgery for that. Then the other study is the Wisdom study. Here is the picture of the CAP study. We work very closely with Dr. Olapati and Dr. Romero and the High Risk Clinic group. This is that I mentioned earlier, and here is the second study, is the Wisdom study. I think by now many people know about this. This is the Women Informed to Screen Depending on Measures of Risk. That's the abbreviation for Wisdom, and it definitely makes sense, because would you rather get a personalized approach? Because I see patients coming every year for that mammogram, yet we find something very small, not a small in situ cancer when they are 70 plus, whereas there could be another group of women who come every year, but still develop a more aggressive interval cancer, which is already spreading to the lymph nodes. So biology of the tumor is different for different people, and their genetic makeup is different. And I feel that's why a personalized approach might be the way to go in the future. The goal is that hopefully once this study, which is a large study, 100,000 women need to be enrolled in this study across the United States. And I think it will eventually, in a few, like 5 to 10 years, will give us guidelines to better understand the safest and most effective way of screening for breast cancer and minimizing the deaths that occur due to breast cancer. And that's all I got when it comes to screening. I really appreciate your time. I would really like to answer questions if you have any. Otherwise, my email address is mentioned on the slides, kkulkarni@radiology.bsd.uchicago.edu. Feel free to send me an email. I'm usually in the breast center on the radiology side. I know a lot of times we don't get to meet all the patients because we work behind the scenes. Sometimes you might see our names on the report, but definitely with this part of radiology, which is the breast, is a very different kind of radiology where we have a lot of patient interaction, and we actually like talking to our patients and understanding what their needs are and being there for them throughout their detection and treatment.
Thank you so much for all that information, Dr. Kulkarni. Really important stuff there. We do want to open it up to Q&A. So if you have a question, you can either type it in the chat box. If it's something of personal nature where you don't want everyone to see, you can send it directly to me and I will ask it on your behalf. You can just send me. For those of you who are joining us on Facebook Live, you can use the comments section to ask any questions that you have, and I will make sure that I check that. I did get a message here asking, someone said, I get annual tomosynthesis screening. And can you explain what tomosynthesis is, Dr. Kulkarni, before we even go on?
Absolutely. So 3D mammography is a newer technique in mammogram. Well, not so new. It's been there now for the past 10 years or so. We have it at University of Chicago, and a lot of places now have 3D mammography. So it's essentially, from a patient perspective, a same experience of getting a mammogram, but when it comes to looking at the images, we don't get one, but a stack of images. The reason is because the tube, when it's taking that image, moves at every 1 millimeter, 1 degree angle, and we get a ton of images, which are then, there is some post-processing that happens, and we get a stack of images rather than one image. The advantage of that is that it's especially important in category C and D breast density to get this, because you're getting a better understanding of the breast tissue. A lot of times overlapping breast tissue could be a reason for unnecessary callbacks. So we've definitely seen that in our practice, we are calling the patients back for additional workup way less because of this technique. And sometimes, like I said, that the dense tissue can potentially mask the cancer, and this technique can help us identify the cancer a little bit more.
So tomosynthesis is the more advanced type of mammography, and it's used at the University of Chicago. Is it standard across a lot of different
Absolutely. It's pretty much standard now. Most of the centers have 3D mammography. We compress the breast. The goal is basically to reduce the thickness of the breast, so lesser amount of radiation can go through, and we can get a uniform image, which is of good quality. So I really want to emphasize that women shouldn't have anxiety around a mammogram. Make it as like a gift for yourself around your birthday. Get that appointment with your girlfriends for that mani-pedi, and get that mammogram along with it. So I want to emphasize that it's not painful. We also have some smart curved paddles in some of our locations, which are shaped like a breast, and they make the experience much more smoother.
Great, thank you. So getting back to this question, it says, I get annual tomosynthesis screening. I have dense breast, but no breast cancer in my family. Should I get further testing, as in MRI?
So dense breast definitely has a slightly higher risk, like I said, of breast cancer. If you are in category C and D, we do offer breast MRI. So you should, just based on your density, get some sort of adjunct screening besides a mammogram. Either you get a whole breast ultrasound examination or a breast MRI, and at our institution, we offer both. But we specifically also offer breast MRI as part of research for patients who have dense breasts. So definitely reach out, look up online, or reach out to me, and I'm happy to arrange for a research protocol breast MRI to be done for you.
So there's a question here. What do you think is the most urgent need for improving breast cancer screening?
I think the most urgent need, first of all, is the awareness. A lot of women are not even aware, or also a lot of women are uninsured and not have the means of getting a mammogram. And there's one more study that I did actually mention, but it's called the SCORE study, which was previously funded by one of my colleagues, Dr. Shep, and it is funded by the American Hospital Association Institute, and it's essentially for women who do not have insurance. And what we could do is at least offer a screening mammogram for them and find out if there is anything concerning, or is there any cancer that we could pick up. So I think the first step is awareness. And the second step is finding the right tool for you, because there are tons of questions. I think the only way you can get answers to that is if you have these discussions with your primary care physician, with your OBGYN. If you have any of those red flags that I mentioned earlier, whether dense breast, Ashkenazi Jew, Jewish descent, chest radiation, at a younger age, family history of breast cancer. If you're a Black woman, I think it's a good discussion to have whether, am I doing the right thing? Is there anything else that could be done?
And I want to also remind everyone that this is a Breast Cancer Awareness Month is a great time to talk to your own family members and find out. Sometimes we don't know if we have that family history. You know, maybe we would know if our own parent had it, but it's possible that someone else did. And so just having those conversations with your family members about what your family history of cancer looks like is so important.
Absolutely.
There's another question here. It says, what type of pain would be a warning sign? Sharp pain, soreness?
Sure. So pain is typically not an indication of breast cancer. Pain is mostly associated with hormonal changes in the breast. And we all typically feel that during, right before our period or right during the period, the soreness or the pain that kind of comes and goes, or pain that is radiating towards the nipple, or pain that is cyclical. Those are all good things. But if you have a focal pain, which is at that spot, and if it's associated with a lump, or if there are any skin changes, then definitely get that checked. But focal pain is something where I would say you need to go and get yourself checked with your doctor.
I have a question here about treatment. It says, what kinds of treatments are typically used to treat breast cancer, and how do they differ?
Yeah, so that is definitely an excellent question, but a very in-depth, very broad answer. Like it would be a half an hour talk in itself, because there are multiple factors that influence, what the treatment would be. So when we evaluate the breast, when we find the cancer, we are looking for other things, like we're staging the cancer. There are sometimes when we do a breast MRI, and in those patients, we're trying to find if the cancer is at one spot or is it at multiple spots. When we say multiple spots, how many spots and how big is the area? And is it in the opposite breast? What about the lymph nodes? Are the lymph nodes looking suspicious? And if there are any additional concerning areas, we do those additional biopsies to actually map the area for the surgeon. That is step one. And then there are these biopsies which determine multiple other factors that tell us a little bit about the biology of the tumor. Where there are some people must have heard of, estrogen and progesterone. These are our hormones, and then there is another one called HER2/neu. These are receptors based on the number of receptors that you have. We can determine what kind of treatment would you be eligible for. So some cancers are invasive, means if there's a cell and there's a membrane around the cell, it's broken that membrane, whereas some cancers remain inside, so in situ. So they remain inside within the basement membrane, within the duct. So depending on all of these factors, we decide whether you need chemotherapy upfront to shrink the size of the tumor, and then surgery, and then assess how the final pathology looks like, and then figure out whether you would need radiation or not. In some patients, we would do surgery upfront, and then the patient might need radiation, and sometimes even chemotherapy. So no one answer to that question. I'm sorry for the sake of time, but it definitely is a team effort. It is definitely a more holistic, multidisciplinary approach. We take all these factors into consideration and chalk out a plan for you guys.
Great. I have one more question here that came to me. It said, how do I know if I have dense breasts?
I think I briefly touched upon that in the talk, but the only way you can know your breast density is when you obtain a mammogram. Breast density is not what you can feel. It's not the firmness of the breast, and it is also not related to your bra cup size. Although in our report, radiologists reported into 4 categories, A, B, C, and D. Sometimes it can be confusing. Are we talking about the cup size or it's the breast density? That's why I wanted to make that clear. So the only way you would know that is by getting a mammogram. And on the mammogram, we radiologists can determine what your breast density is.
Great. I don't see any other questions here on Facebook or in our chat. If there are no other questions, Dr. Kulkarni, real quick, just what's your one big takeaway then for everyone listening on here for Breast Cancer Awareness Month? If they take away one thing from today's webinar, what should it be?
When it comes to screening, give that gift to yourself. Go get that conversation, ask the right questions, and get your mammogram or whatever test that is for you. Because, like I said, not one test is for all, but there are multiple options, and do talk to your provider to figure out what is the right tool for you. And if you are diagnosed with breast cancer, then please do not panic. We're here with you. We are a great team of doctors who are with you through this process, who will guide you and help you through this process.
Great. Sorry, I got one last question that just came in here. If I have density B, if I'm density B, should I look for further screening?
No, not for B. For C and D is what that's what the density law has been passed for. But there are other factors. You might have family history of breast cancer, but based on the density part, if you have category B, you don't need any adjunct screening.
Great. Okay, Dr. Kulkarni, I will let you go. I know that you've got to run to a biopsy, so thank you so much again for being here today. We really appreciate it, and hope you have a great rest of your day.
Thank you for inviting me. Nice talking to everyone. Bye.
You as well. Bye-bye. Okay, thank you to all of you who joined us on our Facebook live stream. We hope you have a wonderful afternoon.